everyone. Okay. Let's just wait for more people to come online first, okay? Hi, Kate. Okay, we're just waiting for Dr. Sandy to come online, okay? So today's session is a bit later. It's 8:30 instead of 8 o'clock because Dr. Sandy, who will be joining us, is actually calling in from America. She's calling in from San Diego. So it's actually only 5:30 a.m. her time. So that's why we delayed it a little bit so that it would be more flexible for her. So thanks everybody for coming online today a bit later. So does anybody have any questions before we start? Okay, you can start asking your questions. I'll take them down. Okay, so we can ask Dr. Sandy when she comes online. So today's topic basically, okay, we're gonna be, although it's mainly topics to do with the US, okay, the reason why we decided to bring in a doctor from the US is to give us a different perspective, okay, because most of us probably know about IVF here in Singapore or in Asia, okay, so we decided that by bringing somebody in from the US to give us a different perspective on how IVF is done over there. Okay, so Dr. Sandy and Dr. Syed is meant to be joining us, but I think, if I'm not wrong, Dr. Syed is not feeling too well today, so I think Dr. Sandy will be the only one joining us. Okay, all right, so what we will be talking about today is IVF in the US versus Singapore, okay? So we'll be answering questions in terms of IVF treatments, egg donors, surrogacy, okay, which is something that obviously is not talked about in Singapore because it's not allowed here, okay, so we'll talk about surrogacy as well, okay, and then we'll go on to answer some patient questions, okay, such as things to do with PCOS, endo, and certain specific treatments. And then finally, we will go through IVF and PGT and whether PGT is something that they would suggest. All right, okay, so let me bring Dr. Sandy on board now. Hi.
Hi. So sorry, I'm a little bit late. I was having trouble with my
No problem.
so.
No problem. Thank you for joining us. I've been telling everybody that it's only 5:30 a.m. your time, so it's really early.
All good. All good. I'm used to it from residency, so all good. Glad to be here.
Okay, so Dr. Syed, he's not feeling too well today, so he won't be joining us, correct?
Yeah, I think he said he was going to try, but I think if he didn't, depending on how he felt, I think I had a feeling that he might not be able to make it. So sorry to miss it.
No problem, no problem. Okay, I'm sure you'll be able to manage all our questions. Okay, so maybe before we start, would you like to give us an introduction of where you're from and what you do?
Yeah, so my name is Sandy Chuan, and I'm one of the 5 physicians here at the San Diego Fertility Centre. And graduated medical school from UCLA in 2003. So I'm kind of scared to say that out loud. So almost 20 years. And the San Diego Fertility, our practice has been around for about 30 years. It was established over now, 1999. Originally physician. And now there's 5 of us, and our focus is only fertility. That's kind of how it works in the United States. Is that it's just a little bit different. We have a system where, in order to become a fertility specialist, you have to do your 4 years of medical school, 4 years of residency as an OBGYN, and then you do have to do the specialty fellowship, which is standardized to be 3 years. I did my fellowship at USD, University of San Diego, California. And in order to become a fertility specialist, you have to do double. So be boarded in OBGYN and boarded in fertility. And our clinic is, run by fertility specialists, standalone biology lab. So we've been around for a long time in this area. And a large part of our focus actually is not only our patients, but because we do third-party reproduction in the United States, we are known for reproduction, but also therefore have third-party patients from international, kind of big international collaboration because of the. So we have about 100, staff members that are both IVF production, like surrogacy and egg donation, and our in-house egg donation program. A little bit about myself. Originally, and I have 3 children and going off to college. So that's exciting. And so,
Yeah.
Yep. And I have forced them all to take Mandarin. It's important. And so that's a bit about our family. They even though they're growing up here, getting their culture. I love photography, baking, I'm Asian, so anyways.
Fantastic. Okay, I've just got a message that Dr. Said is actually trying to come online. Okay, let's have a look whether he can come online. Hello.
Good evening and good morning.
Morning. Hope you're feeling better.
Yes, thank you. A little bit better, thank you.
Fantastic. Okay, so we just did an introduction from Dr. Sandy. Okay, hold on. Dr. Sandy, I think we've lost your connection. Okay, anyway, maybe Dr. Said, you could start off with an introduction of yourself as well, please.
Sure. I've been in practice for about 23 years. First of all, it's an honor and pleasure to be among all of you today and really have the honor of helping you in your journey to creating your families. I did my training at University of California in Los Angeles at UCLA, my residency and fellowship, and I've been in practice for just about 23 years. Really, during those 23 years, my team and I have been able to help many intended parents, many patients around the world achieve their goal of creating their families. Yeah. We've also been very much involved in research and publications because we believe that research really is the gateway to discoveries that could enhance fertility and really maximize the health and the success rates of pregnancies. We've published papers on endometrial receptivity, how do we make the uterus more receptive, on classification of embryos, how do we classify embryos based on their cell structure, cell quality, so that we can select the healthiest embryos to give us the chance of the healthiest pregnancies. We did the first randomized control trials in the world comparing fresh versus frozen embryo transfers.
Okay.
Currently, our research focuses on looking at non-invasive PGTA, meaning that how do we do an analysis, a genetic analysis of the embryo without a biopsy of the embryo, by just looking at the DNA that it sheds into the culture media. So, it's been really an honor and really a privilege to be able to be in a position to help intended parents. As Dr. Chuan said, a significant portion of our work is outside the U.S. Because of our reach, because of our connections, and I think because of our reputation and experience. There are many, many patients that come around the world to seek our help in growing their families.
Wow, that's pretty amazing. Okay, maybe we can start off by okay, I guess everybody online today, because most of the people coming online are probably from Singapore. Okay, I guess their biggest question would be, what is the difference between IVF in Singapore and probably in the US?
Do you want me to answer that question, or
Doctor, you can go, Dr. Sai.
Okay, so I'm not. There are some terrific physicians in Singapore, frankly. I know one of them personally, and he's a colleague and has become a friend, and have a great deal of respect for him and his team. So I know they do a terrific job. I think there are just some focuses that may be different in the United States. For example, individual clinics may have different focuses in regards to IVF. Some are more focused in regards to research, and sort of trying to discover new paths to maximize the chance in pregnancy and health of children born via IVF. There are some that have more experience in genetic analysis of embryos. As we talked about, as Dr. Chuan talked about, there are some clinics that have more experience with surrogacy, egg donation. I mean, we do probably well over 500 egg donor and surrogacy cycles per year. So I think that you really, just like you have to individualize treatment, you also have to seek the care of the clinic that's going to best suit what your wishes are in regards to your fertility diagnosis. I think that in regards to complex IVF cases, surrogacy cases, egg donor cases, I think our clinic is very well positioned in being able to take care of patients.
Understood. How about Dr. Chuan?
I'm going to add just a little bit. I think what I know, not just maybe specific to Singapore, but the world in general, I think that the U.S. is unique in that we do have, before, such a prescribed system for how our physicians are trained in order to become fertility specialists. So we truly are very specialized, and that's all we do. In many other countries, the doctors are OBGYNs that have a focus on OBGYN. They haven't gone through, the 3-year clinical fellowship that we've done. That is a huge focus on research and new data, because it's always constantly changing. As Dr. Donishman mentioned, I also did an additional 2-year research fellowship, and so separate on top of that. So it's really a long road, and we have a very strict boarding system. You have to be boarded in OBGYN and REI, which is reproductive technology and fertility. So, so I think the training is very specialized. Secondary, our clinics are specialized. We focus on just fertility. And then I think the last thing is that, because a lot of our, the majority of the clinics are private and will invest a lot of research, it's just kind of maximizing our success for patients. We have a lot of focus on individualized care, so not cookie cutter for everybody. Really on what your history is, your needs are, and I think there's an investment looking at things as we want to out with needs. And because of interest rates, we are able to do programs, success guarantee programs for many couples with unexpected fertility, for example, that you just don't know why, but they actually have diagnosis. They have young, healthy ovaries, and everything looks good. So really, those patients should have more of a guarantee of success because we're able to offer the unique program. And particularly, I think our center is different in that, even other clinics in the U.S. that we really have space in our embryology lab and all that we can offer. So I think it's also the embryology lab. There's a huge focus there, and research and genetic testing and all of those that make that U.S. kind of the leader in success rate.
Yeah, no, that's a very big comparison. I think in Singapore there's also a lot of rules and regulations that are probably very different from the US. Exactly. Okay, so let's say if we have somebody in the Singapore and they decide that they want to go to the US, let's say to do a full cycle, is there a doctor that would manage them in Singapore and then they go over for a cycle, or would they have to go over for the full treatment?
You could really do either, right?
Okay.
All over the world that kind of juggle the same issue because it is a long time. So we have patients who prefer to have from the start of their care everything done here in the US. We can help them manage that, let them know about places to stay, all those kinds of different things. However, we do have partners in places of the world that can't really. Danisha mentioned we have some good partners in Singapore that are really supportive. They're invested in their success, are willing to help get order medication, do their monitoring, share with us so that the patient start there and really minimize the amount of time they have to do it.
Okay. All right. Okay. I'm so sorry, but Dr. Chuan, your connection isn't fantastic, so we're getting bits and pieces in. Are you using Wi-Fi or mobile data?
I am using Wi-Fi, so.
Okay. Do you want to try using your mobile data instead? Because we're getting bits and pieces, and I want everybody to make sure that they can hear,
I can
you fully. Yeah.
1 second.
Yeah.
Start
Sometimes
with
we get a bit.
Let me see if I don't lose you.
Okay, so I mean, while you try that, in the meantime, in terms of drugs, okay, are the IVF drugs in the US the same as the ones in Singapore? And if there isn't a difference, why should I go to the US?
I think that, well, the medications are going to be the same because the medications are typically manufactured by some main manufacturers, and in fact, there's sort of almost a monopoly on these particular medications by these manufacturers, and they have a global distribution and supply of medications around the world. So the active ingredient in these medications are the same. They're going to be named differently in different countries. So I don't, it's not the medications that's really drives the success of IVF. What drives the success of IVF is, the particular IVF doctor's experience in regards to how to conduct the IVF cycle, the type of medications that are used, the dosage of medication that's used, as Dr. Chuan mentioned, the laboratory team, the entire team that's sort of taking care of the patients. And as we discussed before, our clinic is active in research. We just presented a particular speech at the European Society of Human Reproduction and Embryology, which is ESHRE, which is the main European conference in fertility every year. And then we have 3 papers that are being presented at the American Society of Reproductive Medicine Conference, which is held in Baltimore this year in October. So again, being active in research means that you're able to discover the challenges and some of the more complex IVF cases that exist around the world for patients. When patients suffer from infertility for many different reasons, some are more straightforward diagnoses and others are more complex. So again, I think it goes back to experience. It goes back to research. That's what really is the differential between different clinics, different doctors, different clinics. I think patients should focus on that particular aspect. It's not really the medications that are going to be different around the world.
And I'll just add that I do think, though, there also, in regards to medication, Dr. Stanishma is absolutely right. The medication is the same, but I think it's how you use it. And also there's a willingness, our kind of our perspective of trying maybe more innovative things, new tests, give those a chance to see if it can make an impact in diet, because it is difficult to sometimes diagnose a problem, particularly for patients with unexplained infertility, for example, and like growth hormone. There's different adjuvants, even supplementation. Sometimes, here it's kind of standard for us to share a list with patients that we recommend. Whether or not they make a huge impact, but we feel like every little bit counts, and we're willing to try other holistic approaches.
Understood. So, okay, coming back to the question of, let's say somebody from Singapore wants to get IVF done in the US, okay, how much time should they budget? Let's say they want to go over there to get the whole thing done fully. How much time should they budget for treatment, let's say IVF treatment?
I usually tell my patients that they should budget probably 16 days, just because of arrive the day before, right? That you start stimulation. Most people take injections for about 10 to 12 days, but occasionally there are patients that go through 14 days. And some of my Asian, our Asian patients can sometimes take a little longer just from experience. They might go 12, 13 days, sometimes even 14, which means egg retrieval 2 days after trigger. So that could extend to about 16 days. Even most people will be done probably by the 12th or 14th day, have a day to flight. So budgeting, about that 16 to 18 day, I have patients that want to come a few days earlier just to make sure their jet lag and everything's resolved. So you kind of, want to make sure that you're not rushing it. You can always change, go home a little bit early.
Yeah.
But it's better to not have to stress. But it is quite a bit. I want to be here for the whole thing.
So 16 days would be for the stimulations. Okay, let's say for the transfer, would they have to come back again the next month, or how would that happen?
Yes. You could. I don't want to take all the questions. Dr. Daneshwan, please.
No, absolutely. I mean, on the follow-up question, it all depends on the type of cycle. So in the majority of instances, in most patient categories, the frozen embryo transfer is going to have a higher rate of success than the fresh. So ideally, we would want to freeze the embryos, and many patients opt to have the genetic analysis done, the chromosome analysis on the embryos. So we freeze the embryos, and then depending on whether the patients are using a surrogate or their own uterus, what we do is we wait until they have their menstrual cycle, and then we prepare the cycle, the endometrium or the uterus, for the transfer, which takes roughly about 2.5 weeks to prepare the uterus. So that can extend their stay, or they could have a second trip, back to us. And as you know, many of our patients, many of our intended parents, intended fathers, use or work with a surrogate, in which case then when the embryos are created, then we're able to perform transfer when the ideal surrogate is found.
So let's say in the use for a surrogate, okay, does the actual mother and father have to be there, or can it all be done just like that?
Yeah, it can all be done remotely, frankly. It's, if they're using an egg donor, certainly, as Dr. Chuan mentioned, we have an egg donor program. We have other colleagues with wonderful egg donor programs that we can connect patients to. And then, the surrogate screening and all the testing and everything is done by our clinic, and then the transfer is done. One of the great things about the technology that we have access to now is that intended parents can actually Skype in, they can FaceTime in, they can video call in to the transfer, so they feel that they're part of that beautiful moment when their embryos transfer to their surrogate. So that to us is something special, and we encourage that.
Okay. In terms of surrogacy, okay, let's say if somebody, how would you decide if that person should go for surrogacy or should go for an egg donor?
I think that's a great question. I think many times people do get confused if they're having trouble conceiving. Certainly, I think one of the first things we look at is every woman that comes through, whether or not she's 40 or 30, is about ovarian reserve, because the embryo factor is really key in success. So being able to have a good quality egg, good ovarian reserve is important in case of that. So if someone is struggling with their ovarian reserve and embryo quality, not be able to even achieve a blastocyst, which is a normal embryo around, it should be. But I think it really depends on the situation and how they're. So that's something that you should discuss with your physician. So we will ask patients to do it and bring all of their records so that we can make that assessment. If or if it actually looks quite good and there's something gone quite well, and you've gotten quality embryos, but you just have not had any. So you have implantation, you have fibroids, endometriosis, which can impact implantation. With at surgeries, the implant process. If you have that, then surrogacy is certainly, at the top of the priority. However, I have many that have an overlap of both. And so that right between the doctor and patient on which one to consider first, or do you consider both? So it's very individualized, but you have to look at I think is my recommendation.
Okay, I'm so sorry, Dr. Tran. The connection on your side is still not 100%. So I'm getting bits and pieces from you. I don't know whether it's the room that you might be in. Okay?
I can why don't we do this? Dr. Dashman, take the question. Let me go find
I'm so sorry. Yeah, because I really want everybody to make sure that they can hear you.
Yeah.
Okay, all right.
Okay.
Okay, you try, and then you can, yeah, okay. So, okay, in terms of, I think in Singapore, one of the biggest problems with ladies here is that a lot of the ladies are past the age of at least 38 to 40 years old. And obviously in Singapore, in terms of legal aspects and in terms of government, okay, they usually don't offer much help to ladies who are past the age of 40. Okay, so what is your experience in the success rate with older ladies with a diminished ovarian reserve?
You have to individualize treatment with patients, or every patient, but in particular with patients who are beyond 38 or 40 years of age. Why? Because as patients get older, both the number and the quality of the eggs in the ovaries decline. Based on our research, based on our experience, we have been able to formulate medication protocols, IVF protocols to maximize the chance of success. In some of these groups of patients, even when they're in their 40s, the chance of success could be anywhere in the low 20 percentile all the way to about 60, 65%. It varies. Why? Because not every patient who's 41 or 40 or 42 is the same. We perform ovarian reserve testing to assess the quantity and the quality of the eggs in the ovaries. In fact, one of the ovarian reserve tests called the cycle day 3 estradiol, and FSH is based on a paper we published many, many years ago. So we are very transparent in regards to the rate of success with patients. We perform the diagnostic testing in order to be able to gain a better understanding of their ovarian reserve so that we can better guide them. There are some patients in their 40s, if their ovarian reserve parameters are really poor, meaning that their FSH level is significantly elevated, I think for those patients, working with an egg donor would be the best option because their rate of pregnancy is so low with IVF. And for others, we currently have a 44-year-old patient who's going through IVF, and she actually ended up developing 2 good quality chromosomally normal embryos, and she's going to be working with a surrogate because of her medical condition. So she's going to have a good chance at 44 in achieving a pregnancy. So it's really guiding the patient, being very transparent in regards to what the ovarian reserve parameters are, what the chances are, so the patient can make the best decision. This is we always have to have the patient's best interest at heart.
Yes.
That's how you garner trust, is to be authentic, to be transparent, and to really use all the tools that are disposal to be able to maximize the chance of a healthy pregnancy.
Understood.
And I
Sandy, have you anything to? Yeah.
Am I back? Can you hear me?
It's a little bit better. Let's try.
So bad. I can hear you guys great. So I don't know what the problem is. I
think it's better now. I think it's better now.
Fine. There's no interruption. Sometimes it's a little bit of a drop off at times, Sandy.
Really? Okay. Because I hear you guys great. It's coming through perfect on my end. So I don't know.
It's really good now. It's good now.
Right. Perfect. Yeah.
Okay, good. Sorry about that. I agree with Josh on everything is about individualizing care conversation, and I think giving patients a opportunity to decide if they want to be treated. There's times things don't look perfect. And our job is to let you know the risk benefits. We want to give you realistic expectations. We want to be fair. Also want to give hope there is hope, because sometimes we have patients that come to me for a second opinion, and when the doctor, or maybe they show that that hasn't been captured, and they're 10 cycles, and really probably what they need to do is on to egg, but they still want to do one more round. There are clinics that might say, no, we're going to pretend that not someone who maybe doesn't look to go through, but we really have to have that counseling, and also make that they will try, we will support, but honest. I think building that trust is important. It's really among.
Yes, I definitely think that's important, because you don't want to give somebody false hope and keep on going, wasting their time and everything. Yeah. There is something in the US called a success guaranteed plan. Would you be able to tell us a bit more about that?
Sure. I don't think that that's something that's just across the United States. I think that's actually quite unique to our clinic, and that we do have a success guarantee program. And what that is a program where the patients or parents do have to apply, because it really requires that they're, good ovarian curve, and there's parameters that we're looking at. So there's a qualification. However, for egg donor surrogacy cycles, on that screen that passes a screening process into that program. And basically what allows is for cycle treatment, egg retrieval, unlimited embryo transfers until the patient is alive. And not after you use them, then you would get medication, your egg donor, or surrogate, obviously is part of that next medical fee. So I think it's a dynamic program, and it's quite to our.
Okay. All right. In terms of, let's say, an egg donor or surrogacy, okay, do you guys help find the egg donor, or, is there a list we're given, or how does that work?
So we have an egg donor database. It's comprised of pre-screened egg donors, meaning that all the diagnostic screening tests have been performed on them and completed before they're placed in the egg donor database. That includes genetic screening, genetic recessive mutation screening, ovarian reserve screening to assess their egg supply and egg quality, urine toxicology screening, general health examinations, psychological screening. All that's been done before we place them. And the website is actually called eggdonors.com. You have to create a username and password, and you can access the data. The great thing about our egg donor database is that it's a very thorough assessment of the egg, and you can look at all the different parameters of the screen. For example, you can take a look at the psychological assessment online. You can take a look at the genetic counseling report. Every egg donor has to meet with a certified genetic counselor. We work with Amy Vance, who's the head of Bay Area Genetics in San Francisco. And so she has to have a consultation with every egg donor to go review their genetic and family history, kind of to determine whether there are any potential genetic issues that may be transmitted. So this is something that we offer to all of our patients. And I think we have one of the largest private clinic egg donor databases in the U.S. If patients are not able to find their ideal egg donor among our database, and then we have some wonderful colleagues who have egg donor agencies, egg donor databases, and we can connect patients. We'll always be able to find the ideal egg donor for our patients. That's never been an issue.
For the egg donors, are they from the US or are they from all around the world?
For our egg donor database, the majority of them are within the U.S., not only within the U.S., but within our area, within Southern California, within San Diego. That's the majority of our egg donors. But then other egg donor agencies have egg donors all around the world. So not only, I would say the majority of the egg reside in the U.S.
So, okay, so that's for egg donors. Is there anything for sperm donors as well?
Sperm donor is a little bit different. There are sperm banks in the United States. We work with several, including the local one here in San Diego. And there's some national ones that we have worked with, both myself and Dr. Chuan, for the last 23, 24 years. So, and sperm banks perform the same level of screening, genetic screening, psychological testing, infectious disease testing. All of that has to be done. And we really want to, for sperm donors, refer you to very reputable sperm banks.
Understood. Okay. In terms of surrogacy, okay, I think the biggest question that everybody asks is how much would it cost to do surrogacy in the US? How, like, costing wise, are there different things involved, or how is it just one sum?
I just don't know if my Wi-Fi is, or my connection is any better. I've been trying different in my house. Is it better?
It seems to be better. So
okay. Like you guys are getting a tour of my house unintentionally.
It's a very nice house. Very nice.
I know, you come into the guest room, the office, and now I'm in my kitchen. But and if you hear children screaming later, it's because they're waking up. But so I apologize. But I think the cost of surrogacy, if it's just surrogacy alone, it's probably anywhere between $100,000 to $150,000 just for that aspect. I think it really depends on, you know, the surrogacy you're working with. There's a huge range, you know, compensation, state surrogate listing, and they have, if they need insurance, they put them in, because if they work for whatever reason, that may be involved. So that's but kind of a broader range. And the cost, depending on if you're doing IVF, how many rounds of IVF, you know, and whatnot, then that surrogate.
Understood. Okay, in terms of the legal implications, let's say a surrogacy has your baby, how would you be able to bring that baby back to Singapore?
You're actually in the US, because of surrogacy is legal. Now, it's not legal in every single state, and it's a little bit different. For example, in California, they're a pre-birth order state, meaning that before, you know, when you've gone through contracts with your attorney, signed them with your surrogate, gone to the court to say you're the intended parents of the embryos. And so when you go to the hospital and the baby's born, you get a birth certificate that says that you are the parents. And so for as long as the intended mother certificate, the baby.
So that's quite simple then, yeah.
Depends on the country. Every country is a little different. Some places like in Taiwan or, you know, China, they require DNA verification of parent citizenship, but, you know, what I for that's not the case. It depends on the birth certificate. So if you can have that, then you have your documentation.
Understood. So the paperwork is very important. Okay, so let's answer some patient questions, okay, because we have a lot of patients who have obviously a lot of problems. So let's say there's a patient, she's under the age of 35, but with very low AMH, okay. During stimulation, her follicle growth was extremely uneven, and she ended up with very poor retrieval numbers, okay. What would you suggest that she do?
Well, there are ways in which we can synchronize the follicles so that you have more of an even or consistent follicular growth. And remember that sometimes when you start an IVF cycle and you see the very uneven growth of follicles, you see a couple of follicles that are way ahead in terms of their development, that may not be the best cycle to retrieve eggs. So it's one of the situations where you have to look at the IVF cycle, look at the medications that were utilized. The timing is important. Sometimes the follicles can be synchronized by using a medication called an antagonist. Sometimes it's synchronized using a medication such as birth control pill. Sometimes it's best to actually start an IVF cycle after a natural period. So, and the baseline ultrasound, the very, very first ultrasound that when we assess the is a really critical factor in determining whether that particular month is a good month to start the cycle, because if there are already small follicular cysts in the ovaries or an uneven distribution of antral follicles in terms of sizes, then again, that we may want to hold off on starting the IVF cycle. We may want to use some medications to synchronize those follicles before we start the IVF process. So there are many things we can do. Sort of the conduct of the IVF cycle, how do we manage the IVF cycle in terms of medications, timing, and also preparation before. An IVF cycle is not just about that 10, 12, 14 days of stimulation. Yep. It's also about the month before and some of the things that we do to prepare the follicles and the eggs for the upcoming IVF cycle. And that's something that we do. For example, in the previous cycle, we use medications sometimes like testosterone. We use medications such as estrogen priming. And estrogen priming is one of those the protocols where the number of receptors of the for the receptors for the medications that we use are increased or upregulated within the eggs in the ovaries. So there are many ways we can not only synchronize the follicles, get better development, but have better success. Ultimately, the goal is to retrieve as many good quality eggs as possible from the patients.
Interesting. In terms of, let's say there's a lady basically who has recurrent miscarriages, okay, and they have done karyotyping and DNA fragmentation, but nothing was found. So as Dr. Schwan said, it's unexplained fertility. Would you guys continue doing more tests? Or, I mean, because unexplained fertility is actually really, really big here in Singapore. And I think out of 10 ladies that I know, at least 6 or 7 of them have unexplained infertility. And so how would you help these ladies?
I don't
how would you suggest? Yeah.
But
I don't know if my connection is good, so I'm gonna let Dr. Jonathan go first, and then I'll chime in again, and we'll see. I want everybody to get good information. So,
unexplained fertility for me is not an acceptable diagnosis. To me, there is no such thing as unexplained infertility. Unexplained infertility means that we haven't done enough to be able to discover what the cause of infertility is. So what that tells me is that we need to dig deeper. Much like I'm a big fan of Sherlock Holmes, and you just have to be very observant. You have to dig deeper in order to find the cause of infertility, the reason why the patient's suffering from infertility. And that sometimes could mean further testing. Sometimes it doesn't even mean further testing. Sometimes it means looking at the history of the patient, the testing that she's already performed, or he has already performed, and essentially interpreting the results in order to be able to arrive at the diagnosis. Mm-hmm. So it's not so much sometimes about you further tests and put the patient through further examinations and procedures. Sometimes it's looking to see what's been done so far, and we should always arrive at a diagnosis. Always, and that's something that we teach medical students and residents, and that once you have had a history of the medical history from the patient, once you've reviewed her diagnostic screening, you should arrive at a diagnosis. And unexplained infertility is not an acceptable diagnosis.
So you wouldn't suggest for somebody who had, so if the doctor said, you've got unexplained infertility, you should just go straight into IVF. Would you do that?
No, I think your doctor should be able to tell you why he or she is recommending a particular treatment and what your diagnosis is, because it empowers you. If you know what the issue is, and you know what the potential solutions are, and you know what you have to do in order to be able to arrive at your goal of having your family, I think that's empowering for patients.
Absolutely.
Because for that reason, they need to know what their diagnosis is. And it's just not acceptable, the diagnosis of unexplained.
No, I was going to add that I think that I always, though, do tell patients that there are times when there are tests that we can do, but at that point, you can look at the history. And I think give the patient a list of the differential diagnoses that may be at play. There are going to be times when their prior IVF cycles and the outcome of that is giving an indicator. I always tell IVF can be done, you know, until you can see the egg and sperm together and are you getting a good quality, how are they progressing. That depends on if you're good quality. We have a lot of space, so we know our blastocysts, their patients should, what potential should be their prior kind of over, for example. And if they're not reaching the lamb, that could be an indicator of embryo quality, be a sperm factor or ovarian factor. Egg factor is a big, so a lot of times it is that, you know, it's gathering all the information. Also looking at, you know, in the U.S., there's that, you know, there's to be helpful for women that have unexplained, you know, and take long history of infertility, primary infertility. They were in their 20s when everything looked good on paper, that they may have this or something that plays and unexplained miscarriages, you know. So I think that there are, at this point, we try really hard to answers.
No, I think, I mean, coming from a personal point of view, I totally agree. So I actually have 2 kids, okay? So, but I'm trying for a third, and obviously unable. So they just basically told me, you're facing secondary infertility. So only after doing so much research, and I actually went onto a lot of US websites, I finally found out myself that I have a cesarean scar defect because I had fluid in my uterus. But no doctors here could tell me that. And I think that this is something that, and everyone that I went to just said, oh, it's unexplained. So I do absolutely agree with what you're saying. Yeah.
They didn't look, you have an isthmus still. That's very common.
Yes, exactly. That was the word that I told the doctor. I said, I think I have an isthmus. And they said, could you spell that out for me? Because I don't know what that is.
Right.
Yeah.
Yes.
Okay. All right. So, okay. So in terms of PGT in the US, I think in Singapore, PGT is something that is not, I mean, there's a lot of limitations for it. Okay. So let's say there's a lady who has embryo problems, okay, or embryo quality problems. Would you still suggest for them to go for PGT testing, even though they have minimal number of embryos?
I think the number of embryos, you know, determine whether PGT is indicated or not. I think it's just really the diagnosis of the patient and what we're trying to achieve in regards to the IVF cycle. Meaning that, let's say if you have a patient in her 40s, yes, she's going to make not as many eggs from an IVF cycle as somebody who's younger, but nevertheless, PGT in that particular instance can delineate the chromosomes of the embryos and the embryos that are chromosomally normal, so that we don't waste time transferring embryos that are chromosomally abnormal or increase the chance of miscarriage. Patients suffer with miscarriage when they have chromosomally abnormal fetuses. So PGT is indicated not in every case, but in very specific circumstances. And it always requires a discussion with your doctor, IVF doctor. You know, what are the risks of PGTA? What are the benefits? And what are the limitations? Because PGTA can't diagnose every genetic mutation, every genetic abnormality. And what we're trying to achieve is sort of the methods and protocols that are going to maximize the chance of that patient getting to health. PGT is a very important arm in our sort of armamentarium of IVF protocols that we have, and we always have a very thorough and engaging discussion with our patients about, okay, we feel that PGTA is necessary in this particular circumstance, but in many other circumstances, it may not be necessary. For example, if you're working with an egg donor and the sperm quality is very good, then PGTA may not add that much to the ultimate sort of live birth rate or potential decrease in miscarriage rate. So it's really a good discussion to have, and I'm glad you mentioned it, Kim, because it's a really important factor in the conduct of the IVF cycle and the protocols that we use.
In terms of, just now you mentioned risks to the embryos being compromised when you do PGA? What kind of risks are involved?
I think in regards to the risks have really diminished significantly, because in the old days, and we used to do day 3 embryo biopsy. In other words, when the embryo was 3 days old and only about somewhere between 4 to 8 cells, we used to take 1 cell, and so there was a significant volume reduction in terms of the number of cells of the embryos. These days, the techniques have been really refined in PGTA, especially in labs that have a lot of experience in PGTA. And with the sort of refinement of techniques, there's very little evidence of harm to the embryo when we do the PGTA. Now, there are exceptions to the rule. There are some patients potentially where that could happen, but in the majority of instances, the rate of harm to the embryo is going to be minimal or not present because of the refined techniques, and because the experience that the lab has and the embryologists have in the technique of PGTA. Having said that, the next frontier in PGTA analysis is non-invasive PGTA.
Yeah.
That's something that we're part of the ongoing research. And so our hope is that within 6 months, within a year, we will be able to offer non-invasive PGTA where we don't even have to touch the embryo. We're just analyzing the DNA in the culture medium.
Yeah. The US honestly sounds so advanced in comparison to Singapore. In terms of, I think supplements, okay, we've had a lot of doctors come on board who some have said, okay, you need supplements, and some have said you don't need supplements. Okay, what's your take on supplements?
I think that it's difficult to do research in this area. So if you were going to practice just evidence-based and say, this has this much effect, it's difficult to give patients that type of. However, I think that looking at a holistic approach and saying just having healthy living is never going to be harmful. I think that there, whether or not it's going to dramatically, improve your success rates, I think never tell a patient that take all of the things that's going to dramatically improve. But I think my approach, I don't believe it's going to hurt you. I don't want to be stressed about it. I don't want that anxiety. But at the same time, I think, there is some evidence on some of these antioxidants being helpful in protecting kind of cellular from generalized oxidative stress that's in the environment. So I encourage you to be on a fairly simple regimen of antioxidants and, omega-3 and other, vitamin C, kind of just a healthy living perspective when it comes to supplement. So I do encourage it for men and women. And a diet, a Mediterranean diet, just eating healthy, organic, I helpful, although I don't want to be an added stressor for patients.
Okay, all right. And how about you, Dr. Said? Anything to add to that one?
No, I think Dr. Chuan really eloquently reviewed that. With supplements, you got to be just careful that it's not the sort of the panacea. It's not the cure-all for decreased ovarian reserve or sperm factors, but they could be used as an adjunct, as a way in which we could potentially make sure that we leave no stone unturned in the treatment of patients. For example, if you have a male who has significant abnormalities with the sperm, as Dr. Chuan mentioned, good nutrition is important. Green leafy vegetables that are higher in zinc and folic acid are important, but taking a supplement that has some antioxidants, including vitamin C, folic acid, L-carnitine, that can't hurt. There may be some minimal positive effect, and so we do recommend those particular supplements in those particular circumstances. So I do think you have to be careful in recommending supplements as sort of the cure-all, as something that's going to really overcome fertility. That's not the case. There's no research evidence that shows that that's the case. But as an adjunct in the treatment of fertility, they can sometimes be helpful.
Understood. Okay. In terms of, is it important to choose the right doctor? And if you don't succeed at a particular clinic after one IVF cycle, would you recommend them changing doctors?
I, I,
We're going to be objective here. I think,
Okay.
right? I think that the reality of it, you do need to be thoughtful about the clinic that you're working with. It's not just about the doctor. I think it's about the whole team, right? And it's the team approach, the embryology lab, their overall track record. I think one way that you can try to evaluate success rates is actually taking out all the different factors of the patient. But if you just look at egg surrogate success rates, that gives you a very good equalizing kind of factor that tells you the quality of the lab. Secondarily, I think your physician does matter. That's why you have consultation, so you can understand kind of, your interaction, your case. I'm comfortable with that. So open communication. And then on top of that, I do think after one round, I think it may be premature to switch clinics unless you've had a horrible experience from some other perspective,
Yeah.
So I think it really just depends. But I think most of the time, that first round, this will make a patient then give the clinic and the physician a chance. And you should discuss why it's successful, and that makes part of your decision.
I agree. Okay. We've got a question coming in. Do ladies in the US do TCM, acupuncture?
so the acupuncture is offered in the US, and there are many patients who do undergo acupuncture. Like many of these particular sort of supplemental therapies for IVF or for infertility, I think that the data is still doesn't support a significant increase in or statistical increase in pregnancy rates with there are some studies, some retrospective studies that show some potential benefit, but at least up to now, research studies really haven't shown a definitive positive impact on the outcome of embryo transfers or IVF. Now, acupuncture does have benefit in many other areas of medicine, but it's still unknown whether it has a positive impact on fertility. So far, the research studies don't show it. But we don't discourage patients if they want to undergo acupuncture. We don't discourage them because we also don't think that there's any harm to doing acupuncture. But it just, again, you have to look at the data. You always go back to the research data to look at to see what it shows. And thus far, there's no good research data that shows it has a positive impact.
Understood. I think here in Singapore, it's really big. So I think out of 10 ladies, 8 of them would be doing TCM. And so when a lot of these ladies don't succeed, they say, oh, maybe because you should have done acupuncture and things like that.
Yeah. And I also definitely don't think that when IVF cycles don't succeed, it's because of the lack of acupuncture. I think I want patients to know that that's not the reason that you're not going to be successful.
I think so, but I kind of tell my patients that if you feel like part of so much stress in the process, and if I tell them not to stress, that's possible, right? Everybody's stressed in the IVF cycle, so it's really in a way I call it stress distraction, stress management, and so to distract yourself, there might be other things, and so in some ways, I've been to acupuncture, and it is even then. Some people that time they could have. I think if it helps with your stress level to just have that limit, I think that could get that. But don't think that that's going to be the imperative thing that impacts success rate. Could it be something that helps you kind of from that other perspective, stress, distraction, stress management? I think it can be. So I don't encourage that. I want to make sure they're mentioned. And I agree with you.
Okay. All right. To end things off, okay, let's say if a lady wants to contact San Diego Fertility Centre for IVF in the US or for certain advices, what should they do? Who should they contact?
They should contact you, Kim, so you can refer them.
So actually, we have many liaisons, but actually, I think probably the first step is that we do have our new lactation coordinator and to schedule a consultation. And we certainly could share her contact information so that we can at least get the patient started in the process. And then our kind of liaison team, we have a team that can take over to facilitate that process.
Okay, we have one last question. Yeah.
Also post on the comment section, post kind of the emails, you know, to contact our liaisons.
Yes. We will do a post with information, and we will try to answer some of the questions that we asked today that Dr. Chuan answered. So we will put them in the slides so that people get the answers, just in case they didn't hear them properly. Okay, one final question. I think it's on a lot of people's minds. Do you recommend taking the COVID-19 vaccine before doing IVF or during IVF?
We certainly recommend the COVID-19 vaccine for everyone because, frankly, it's been so effective in real trials in the real world. In fact, there was an interesting article the other day saying that both Pfizer and Moderna may actually not be as profitable because their vaccines have been so effective. So there may not be even any need for boosters because there's the initial study coming out of the publication Nature that shows that immunity may be present for several years from the vaccine. So we recommend vaccines for everyone, and we recommend them as soon as possible. Now, if as soon as possible means before the IVF cycle, great. If it means during the IVF cycle, not as ideal, because during the IVF cycle, during that 12 to 14 days of stimulation, our only concern is that if the patient has side effects from the vaccine, fever especially, that may have an effect on the ultimate outcome of the IVF cycle. So it's always better to do it prior to starting your IVF cycle, finish your regimen so that during the IVF cycle you don't have to be concerned. The other issue is the egg retrieval is performed under anesthesia. And so, if, for example, someone were to be infected with the COVID-19 vaccine and then now they undergo anesthesia, that may increase the risk of pneumonia, some other complications. So it's always better to have that done and your vaccination completed before you embark on the IVF journey.
And sorry, I'm just going to add one thing. It's not that we feel that the vaccine itself negatively impacts fertility. That's a big question.
Yeah.
Quality, sperm, it's not that. It's just that as a response to the vaccination, it's normal to have a fever for a minute. And that fever is what we're trying to avoid that. So there's no other side effects. So that's why we encourage to do it before their IVF or their fever that Dr. Daneshwan mentioned. And we kind of want to avoid that. And some people feel nothing, but then have 12 hours of fever. So avoid that.
So in terms of, let's say, after taking the second dose of vaccine, would you wait out a month before you start the cycle, or would you be able to start straight away?
You can really start straight away because the side effects, as Dr. Chuan mentioned, it's only typically about a day or two after taking the doses of the vaccine, and then they dissipate and you can start your IVF cycle right afterwards. Okay.
All right. Thank you so much for coming online. Okay, we've taken about an hour of your time, but thank you so much for taking your time out and answering your questions. As we said, we'll get some answers written down in slides so that we can share them out, and we will also put down San Diego Fertility Centre's details on our website so people can look for you guys if they want.
Absolutely. And Dr. Chuan and I will also, we'll send, you have our emails as well, so the patients can contact us by email as well.
No problem. Thank you so much, and have a good day.
Sure.
Thank you.
Bye-bye.
All right.
Thank you so much.
Bye.
Bye.
Bye.